Thank you for joining Cancer Support Community Atlanta for Frankly Speaking About Metastatic Breast Cancer, facilitated by Dr. Rangaraj with Atlanta Cancer Care and moderated by Emily Beard with Northside Hospital Cancer Institute. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. Welcome everyone to today's program, Frankly Speaking About Metastatic Breast Cancer. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we welcome you and invite you to visit our website, cscatlanta.org, where you can see a complete list of the free virtual oncology programs offered. These do include virtual support groups led by licensed mental health professionals, and I do want to highlight that we have a metastatic breast cancer support group that does meet. We also have stress reduction classes like yoga and Tai Chi, monthly nutrition seminars facilitated by oncology dietitian with Northside Hospital Cancer Institute, and cooking demos as well. We also have education programs like these. So for a complete schedule of events or to register for any of these programs, again, please visit our website, cscatlanta.org. As a reminder, everyone will remain on mute for the duration of today's program. We do invite you to enter questions into the program chat box, which will be addressed at the end of the program, time permitting. I'm excited to welcome today's program moderator, Emily Beard. Emily Beard is the Program Coordinator overseeing breast cancer program development at Northside Hospital Cancer Institute. With a bachelor's degree in nursing from Emory and certifications in oncology nursing and breast cancer care, Emily has worked as a nurse navigator, patient advocate, and program coordinator. She has a special interest in metastatic breast cancer and developing initiatives for young people with cancer, specifically in the areas of hereditary cancer, fertility preservation, and sexuality and intimacy. So with that, welcome Emily. We are excited to have you here, and I'm going to pass it off to you to begin today's presentation.
Thank you so much, Katie. It's great to be here. It's nice to see some familiar faces and also some new faces. So I'm excited for this program. And without further ado, I'd like to introduce Dr. Rangaraj. She is a board-certified hematologist and medical oncologist who practices at our Atlanta Cancer Care clinic up and coming. We are so thrilled that she joined Northside about within the last year. It's hard to keep track of time in a pandemic, but it was within the last year, with over 23 years of experience in the medical field. So her clinical interests in oncology include breast, GYN, lung, gastro, head, neck, as well as blood cancer and hematology disorders. Her training was in internal medicine at Park Ridge and Hospital at the University of Rochester, and she completed a fellowship in oncology at George Washington University in Washington, D.C. So really, really happy to be partnering with her on this program, and I'm going to turn it over to her to get started. So thank you all, and we'll have a Q&A at the end. So if you've got questions as she's speaking, if you'll just put them in the chat box, we will get to those as we go along. Thanks so much.
Thank you so much. Thank you. Yes, it's wonderful to be here. And I really appreciate all of you spending your lunchtime with me talking about this subject. So we will dive right in. I have no disclosures. So what is metastatic breast cancer? Basically, it's cancer that has started in the ducts or lobules of the breast and has spread outside to any organ, such as the liver, lungs, brain, skin. It does not include the underarm area or the axillary area. It's also referred to as stage 4 sometimes, and as well as advanced cancer. So once you have a diagnosis of metastatic breast cancer, you will be referred to someone, a medical oncologist, perhaps a surgeon or a radiation oncologist. And you will soon develop your team that you trust and that you will be looking to for answers. It's important to have a healthcare team that you trust. You want somebody who has expertise in treating your disease. It's important to know that you can communicate with them freely, and that your voice is respected and heard by your healthcare team, and that their goals are in line with your goals. You also have to consider where you live, what the distance is to your clinic. Also, does your insurance cover the cost of care at that particular facility? Are they in network, out of network, as well as what hospital your provider is affiliated with, since this may become necessary sometimes to be admitted for surgery or other issues. You need to know that you're comfortable being at the hospital that your provider is affiliated with. It's important to be able to ask your team any questions, even if you feel that it may not be regarded as a very intelligent one. There are no stupid questions. This is very new to you. Feel free, you should feel free to ask. Also, if you are not comfortable, or even if you are and you just want to get a second opinion, you should be able to do that. You should ask your doctor to either refer you to someone that he trusts, or if you have someone in mind, you should be able to ask your doctor, hey, can I go ahead and see this physician just for a second opinion? Make sure everything is being done correctly. You should not feel that that is something that will be looked down upon. To prepare for your visit, you should bring a list of questions to your appointments, and also ask your team what the preferred method of communication is. Some of the physicians are accepting emails from patients, text messaging, phone calls, or do they just want to talk to you in person? Other important things to ask your physician and your team is, what type of breast cancer do I have? What treatment is being planned? What are the specific side effects of treatment? And what are the goals of treatment, and are they in line with your own goals? It's also important to discuss what over-the-counter medications, herbal preparations, and supplements you're taking, what prescription medications have been given to you by your other providers. Ask if those treatments will interfere with your cancer treatment in any way. And if so, what are those complications that can happen? And could taking these over-the-counter medications, vitamins, and other supplements, could they be of benefit to you? So how is the treatment for metastatic breast cancer different from early stage treatment? Well, we are trying to minimize disease spread. We're trying to improve quality of life or preserve your current quality of life. We want to manage symptoms that are from your advanced cancer. We want to maintain your everyday functioning and, of course, extend life. So the questions to talk to your doctor about would be the type of breast cancer you have. There are 3 general subtypes. One that is hormone receptor positive, one that is HER2 positive, or triple negative. It has prognostic implications as well as treatment implications. So you do want to know this information, and ask which treatment they're recommending and what's the rationale for that treatment. And how will we know if the treatment is working? Are we doing blood tests? Are we doing physical examinations? Are we going by clinical symptoms, or are we going to be doing some kind of imaging, whether it's a PET scan or a CAT scan or a bone scan, etc.? What are the short and long-term side effects of treatment? And if you have those treatments, what's the best way to let your team know that you're experiencing them? And when do I know, and how do I know when to report a side effect? What support services are available for me and my family? And as far as managing the cost of cancer care, will that be covered by my insurance? Is there other assistance available? And am I eligible for any clinical trials? And if so, when? So breast cancer treatment can be divided into 4 different sections. There's hormonal treatment for those whose cancer has estrogen and or progesterone receptors, chemotherapy, targeted therapy, and then immunotherapy. And also you may receive treatment through a clinical trial, although that is going to encompass one of the above 4. Sometimes we utilize surgery or radiation. This is for palliative purposes. This is to treat pain symptom or some other symptom that you may be experiencing. Generally speaking, we use systemic treatment. So that's treatment basically that is treating your entire body, not just a specific tumor mass or specific area of your body. Your doctor will look over the 4 treatment possibilities and decide on which one is best for you based on the severity of your symptoms, as well as the location and the extent of disease. And of course, we have to look at the person as a whole and see, are they elderly? Can they tolerate very rigorous chemotherapy? We'll look at your health status. And we also take into account your personal goals. The other things that impact treatment is the subtype of cancer, such as, does it express hormone receptors? Is it HER2 positive? Is it triple negative? Do we have BRCA positivity? And are there other biomarkers or genetic mutations that are present that can be targeted with various treatments? So looking at the 4 various classes of treatments, basically clinical trials are appropriate for any type of metastatic breast cancer, as is chemotherapy. For hormone receptor positive cancer that is HER2 negative, we use endocrine treatment or hormone treatment, as well as targeted therapy. For cancer that is HER2 positive and ER positive or PR positive, again, we use hormone treatment, and we use targeted therapy that is specific for HER2 part of your cancer. For cancer that is just HER2 positive, but is estrogen and receptor and progesterone receptor negative, we obviously cannot use hormonal therapy there. It is not going to be effective. And then for a triple negative cancer where there is no estrogen receptor, progesterone receptor, HER2, we use chemotherapy or immunotherapy. We do not yet have targeted therapy, and hormonal therapy is not effective here. For triple negative cancer that also is BRCA positive, we can use targeted therapy against the BRCA part of it, and chemotherapy is appropriate here as well as immunotherapy. So first, going to the estrogen and progesterone receptor positive cancer, we want to take the estrogen and we want to deplete it in some way. And there are many different ways in which we do that. So we can either block the estrogen receptor. So this is protein that is on the surface of your cancer cells that binds to the estrogen and the progesterone that's in your blood. And that estrogen can then gain entry into the cancer cell and drive it to grow. So there, what we can do is use drugs like tamoxifen and tamoxifen, and we basically block that estrogen receptor so the estrogen has nothing to bind to, and therefore it cannot gain access to the cancer cell. There are other ways, such as by using medications called aromatase inhibitors. So these are for postmenopausal women. These are women that are done with their menstrual cycles, either by having surgery done in the past, or they have just by way of aging, basically have stopped making any estrogen and are no longer having their menstrual cycles. These women do have some estrogen still, even though their ovaries are no longer making estrogen. This estrogen actually comes from male hormones and testosterone that is then converted into estrogen by way of an enzyme called aromatase. So by inhibiting or blocking that enzyme, we can stop the conversion of male hormones into estrogen. And there are three of these. There's anastrozole, there's exemestane, and there's letrozole. And these three, for the most part, are all about the same as far as the side effects and how efficacious they are. There are other ways to get rid of the estrogen, and this is done by downregulating the estrogen receptor. So here what we're doing is we're basically causing that protein to not be produced any longer. Other ways to deplete estrogen is by giving medications such as Goserelin or Lupron. These are injections that are given every month or sometimes every 3 months. And what they do is they cause a decrease in production of various hormones by your brain that in fact goes ahead and tells your ovaries not to make the estrogen. So this is yet another way. And naturally, this is a strategy that's employed just in premenopausal women, so women that are still menstruating. So this is important, particularly if you are estrogen receptor positive, meaning your cancer has that ER and PR positivity. It's important to discuss your menopausal status. There are women that are still menstruating late in their 50s, and so we cannot assume that you're done with your menses since it has an effect on the treatment we choose for you. Of course, we'll be looking at your hormone receptor status and whether or not you are on hormone replacement therapy in the past or at present. If you are on hormone replacement therapy at the present, that would need to be discontinued. And also we'll discuss side effect management of these medications. Next, coming to the chemotherapy section, we have generally 5 broad classes of chemotherapy. In the anthracycline group, we have adriamycin or doxorubicin, and then we have a doxorubicin preparation that's been changed up some way. It's called Doxil. We have the epirubicin, highly effective drugs for breast cancer treatment. The next very highly effective class is taxanes, and there are 3 drugs here: docetaxel or Taxotere, paclitaxel or Taxol, and then Abraxane. Thirdly, we have platinum-containing compounds, and there's 2 of these. There's carboplatin and cisplatin, highly effective for all breast cancer types, but particularly in the triple-negative subtype. And then we have the anti-metabolites, and these are the 5-FU, the Xeloda pill, as well as Gemzar. And then we have the microtubule inhibitors. There's Erbulin or Halaven, there's Exempra, as well as the Navalbine. So some of the issues to discuss with your doctor: do we just do one chemotherapy drug, or do we use multiple? Generally speaking, for metastatic breast cancer, we want to use one drug at a time and sequence one after the other. Occasionally, we may pick combination therapy, particularly if there's a great burden of disease, to quickly get a response. However, combination will have a little bit more side effects. We discuss frequency of treatment, such as, is it going to be once a week, once every other week, once a month, etc. Also, we can lay out if there are any oral agents available for their ease of administration, any health concerns that you may have that may affect tolerance, such as your inability to swallow maybe, in which case we will not use the oral agent. If you have pre-existing cardiac disease, there are certain drugs we will try to avoid. Also, your preferences, if you don't want to lose your hair, then there are certain drugs we want to use. And then how comfortable you are with the various side effects. Also, cost of treatment becomes very important here, particularly with the oral agents. Sometimes there's a big out-of-pocket cost, so we need to take that into account, as well as side effect management, and then, of course, clinical trials. So this is the third class of treatment for metastatic breast cancer. These are targeted agents. For the HER2/neu class, in which we have HER2/neu protein is being expressed on the cancer cells, these are the targeted agents. The most common one, or the first one on the scene, was the trastuzumab. And then since then, we have some biosimilars. So basically, they're biologically similar to Herceptin, and for the most part, they're interchangeable. The second one on the scene was the Perjeta, both incredibly effective for HER2/neu type of cancer. And then we have the oral agents. So these are what's called tyrosine kinase inhibitors. They're specifically for the HER2/neu class. We have lapatinib or Tykerb, we have neratinib, and then we have the tucatinib. So these are all oral agents, and they're generally used after the IV that I showed on the previous page. They are combined in many different ways. If you are estrogen receptor positive and HER2/neu positive, we may choose to use one of these drugs with the endocrine treatment that I previously discussed, or they can be combined with Xeloda, which is an oral chemotherapy drug. Combination generally does better as far as effectiveness, but they can be used as single agents. The next class is a class where the anti-HER2/neu treatment is combined with chemotherapy. So here we have Kadcyla, which is the trastuzumab that is attached by a linker molecule to a chemotherapy. And here the antibody will attach to the cancer cell, and then the drug kind of jumps inside the cancer cell and does its work. Another one, a fairly new one, is again Herceptin or trastuzumab that is attached to yet another different type of chemotherapy, but works in the same way. And then lastly, we have sacituzumab, which is currently only approved for triple-negative breast cancer. It's in here with the HER2/neu, but it is for triple-negative breast cancer. We have another type of treatment for estrogen receptor positive cancer that is HER2/neu negative, and this is Avrolimus. And this attacks another pathway by which cancer cells grow. And this is an oral agent given by mouth, and it is sometimes combined with Faslodex, which I'll discuss in a short while, but sometimes it is combined or given with tamoxifen or even Aromatase. So for HER2/neu negative cancer that is BRCA positive, we have two oral agents. We have Telzena and then Lynparza. So these are specifically for BRCA positive patients. Then in the HER2/neu targeted arena, in patients that are, the estrogen receptor positive setting where there is no HER2/neu protein, we have three very effective drugs. We have abemaciclib, palbociclib, and ribociclib. And again, these have really, over the last decade, just changed the landscape of HER2/neu positive cancer. They are often combined with another endocrine agent, such as letrozole or Femara or Arimidex, and sometimes they're combined with Faslodex injections. We also have a Pic3c inhibitor. This is specifically for women that have had progression of their cancer on just endocrine treatment, as well as on the CDK4/6 inhibitors. And this drug is called Pic3c. It is available orally, and it can also be combined with Faslodex or given by itself. So again, some of the things to discuss with your physician is the HER2 status of your cancer. Are there other biomarkers that can be tested? Have you tested positive? And if so, what are the targeted therapies available to treat them? What other targeted therapies are available, as well as clinical trials? The next broad category of treatment for metastatic breast cancer is immunotherapy. Here, your own immune cells are altered by these drugs, and they recognize your cancer cells, and then they go on a mission to destroy cancer cells. There's 2 drugs that are approved specifically for triple-negative breast cancer. First one is Tecentriq, which is for triple-negative breast cancer that is PD-L1 positive. So PD-L1 is a test that is done on your cancer cells. If you have more than 1%, you could be eligible to be treated with Tecentriq. It is combined with a chemotherapy drug called Abraxane. This was the first immunotherapy drug that was approved for metastatic breast cancer, and at present is only for triple-negative type of breast cancer. We don't have that on this slide, but pembrolizumab or Keytruda is also approved, again, for triple-negative metastatic breast cancer in those that have a PD-L1 level of 10% or greater, and it can be given as monotherapy. So clinical trials are very important. This is how science is progressing. Basically, we're testing to see if the standard of care or the drugs that we're currently using, is there anything better out there? And we test the standard of care against maybe a new regimen to see which one comes out on top, and then we adapt that as our treatment moving forward. Additionally, this is a way in which we test novel drugs. So drugs that have never been used, to see, are they toxic? What's the appropriate dose? Who do we use it for? And of course, are they effective? So it's important to talk to your doctor about clinical trials. Some of the physicians will look at it early on, others will wait until they have kind of gone through a number of conventional treatments, and then they will look at clinical trials. But these are very important in that they can provide some additional treatment options, but also give you an opportunity to advance science. So there are a number of side effects that are associated with all of the different treatments that I mentioned. It's important to ask your physician what you can expect to have. Although a number of them will be mentioned, not everyone will get every side effect. It also helps to be prepared, asking about what specific ones you can expect with your treatment, how do you report them, what can you do at home about them, and what medications can be used to combat those side effects. Some of the common side effects, particularly from chemotherapy, is hair loss, nausea, vomiting, diarrhea, and constipation, change in appetite, sensitivity of the mouth. Fatigue is a common one, difficulty sleeping, especially if you're on steroids, changes in nails and skin, as well as hair. Lymphedema, really not so much with chemotherapy, but neuropathy is a very common one. Also, chemotherapy can cause premature ovarian failure, which can lead to menopausal symptoms such as decrease in libido, vaginal dryness, as well as hot flashes, cognitive and emotional changes. Immunotherapy does have side effects. However, they're generally mild, so most people can tolerate these drugs very well. However, sometimes unpredictably, some individuals will get very severe or even life-threatening side effects. These agents can affect really any part of your body. So the most common ones are going to be those that affect that thyroid. So your thyroid can become either hyper or hypo. Hypothyroidism sometimes necessitates treatment with thyroid replacement. Of course, every time you're getting these treatments, your physician is monitoring your thyroid levels very closely. The next common one with immunotherapy is pneumonitis or inflammation of the lung tissue. Here you can have wheezing, cough, shortness of breath, or fever. So if you're on these drugs, it's important to mention this to your provider, as well as if you end up going to the emergency room, to let them know that you're on these drugs. Colitis is also a common one, and it presents with abdominal cramping, pain, diarrhea. And then there are others such as inflammation of the liver or kidney, or generalized muscle aches, muscle weakness, joint pains, and rash is a very common one. So these are some of the immunotherapy side effects: diarrhea if you have colitis, difficulty breathing if you have inflammation of the lung. You can have difficulty with tearing of the eye pain, nausea, vomiting, abdominal pain if you have colitis, or severe weakness if you have any kind of endocrine difficulty. So along with the thyroid, it can affect your adrenal glands. Sometimes you may need to be on adrenal replacement, which is steroids. It can cause other symptoms that are listed on this page, even though, although these are not very common. So aside from active cancer treatment, there's also supportive care, or what we call palliative treatment. Palliative care is important right from the beginning, as it can provide you with some very important symptom management care, along with care for your caregivers, support for your caregivers. There's bereavement support available through palliative care. There's sometimes psychologists as well as psychiatrics that are available through palliative care. It can be done at any stage in your cancer care, including at the time of diagnosis. This is a team of specially trained healthcare professionals who are working closely with your medical oncologist, your surgeon, your radiation oncologist, and they help focus on things that will alleviate your suffering, your symptoms, and they help focus on social activities and other activities that are important to you. Sometimes it's confused with hospice. It's not the same as hospice. Hospice care basically means care that's delivered in the last few months of your life. Of course, we know with the great advances in treatment of metastatic breast cancer, it is not uncommon to live a very, very long time. So palliative care becomes very important. Some of the palliative treatments that are available that we employ is surgery, which generally is going to be carried out if you have a symptom from a specific cancer site. So for example, if you have abdominal pain from cancer that's growing in your abdomen, you may be referred to the surgeon to have that removed, just to alleviate the pain, and that we would continue on with your systemic treatment. Oftentimes we use radiation therapy. This is particularly useful in the case of bone metastases, which can be very painful condition. So we may ask for radiation to be delivered to a painful bony site. Also for brain metastases, to decrease symptoms such as headache, nausea, vision changes. Here, radiation treatment can be given just to the metastatic area itself, or sometimes to the entire brain. One of the strategies one of the treatments that we use for bone metastases is medications like denosumab and bisphosphonate, so that's zoledronic acid, and pomegranate. So these medications are very effective, specifically for bone metastases. They're called adjunctive treatment. And what they do is they do help with pain, though they're not pain medication per se, but they retard the growth of cancer in the bone. And most importantly, they protect the bone from getting weak and fracturing. So also, when we are using these medications, we will ask you to take calcium and vitamin D supplements, along with foods and vitamins that are rich in calcium and vitamin D. So lastly, this can be a very difficult time for patients once they're told they have metastatic breast cancer. There's loss of hope, loss of control over your life, over your treatment, and also there's living with uncertainty of what's going to happen next. And then there's also a social isolation that happens where people feel they're alone in all of this. And these are some of the concerns that we noted in a registry of metastatic breast cancer. There's worry about the future and what lies ahead. There's a lot of fatigue related to the treatments as well as cancer. There's money concerns. There's loss of jobs sometimes. There is maybe nutritional issues, difficulty eating, loss of appetite, loss of productivity, loss of mobility, worrying about your family, feeling like you may be a burden, or feeling like they're unable to care for you. There's oftentimes anxiety, depression, insomnia, as well as changes or disruption in work, school, or home life. Of course, pain and discomfort as well. So all of these can impact cognitive functioning, cause behavioral and social issues. It can impact your emotional well-being as well as your spiritual functioning. It's important to discuss these issues with your physician so that you can get the help that you need. If you're experiencing fear, anger, depression, anxiety, sadness, or panic, it's important to talk to your physician so that medications or perhaps group therapy or can be employed, and sometimes a referral will be necessary to either a behavioral health specialist, a psychologist, or a psychiatrist. Some of the things that help is having a positive attitude, a sense of optimism, as well as having hope about your situation can help to bring about relief from some of these adverse symptoms. Also, social networking, continuing to do things that you enjoy doing, engaging with your family, getting support from your friends, and talking to them also can be very helpful. Expressing your emotions can lead to improved physical and mental health, and greater ability to have control over your emotion, greater self-confidence and assertion, and greater expression of support, empathy, interest, and humor. Whereas if you have repressing emotions, this can lead to aggressiveness, hostility, social isolation, and having irresponsible and inconsiderate impulses. These are some of the ways in which you can cope. You can talk openly with your family or friends, somebody you trust. Support groups can be very helpful. There are online resources such as www.mylifeline.org. Talking to a trained mental health professional or clergy can help. And also doing the things that you normally enjoy, such as art, music, writing, gardening, cooking, yoga, and exercising, such as daily walks, can help as well. So these are some financial assistance that's available. As you know, cancer treatment can be costly. There's insurance. Sometimes the hospital will have a financial assistance program. Sometimes there are public foundations that can assist. Sometimes the manufacturer of the drug will have a copay assistance program. There are programs to assist with transportation, occasionally child care, as well as caregiver expenses. And this is information here about getting some of this support, cancersupportcommunity.org. Once you're diagnosed with metastatic breast cancer, it's important to have a living will or advance directive. It lets your healthcare team know what kind of medical care you would like to have if you cannot decide for yourself. Also, a durable power of attorney is needed who can make decisions on your behalf. It can be anybody, doesn't need to be an attorney, somebody who can make decisions for you if you're unable to do so. A financial power of attorney is a person who will make financial decisions for you and your home. DNR order allows you to have a natural death. If you wish to be what we call full code, it's important to discuss that with your physician as well. And then a will designate who will receive your assets and your belongings and who will take care of your children in your absence. So I will conclude my discussion at this point in time.
Thank you, Dr. Rangaraj. I just, did you want to go over the resources? It looks like we've got listed some of the local resources here in Atlanta, in our Atlanta community through Northside. So those are there, and we can make this available for you, anybody that wants more information on any of these. I think Katie spoke about the cancer support community earlier and all of the great resources, both support groups as well as educational and mindfulness and art and every possible kind of offering you may need. We also, our next week, there's going to be a series that Northside is helping to present with Komen, and it's focused on young women with metastatic cancer, but that's what that Komen Impact series is. And then we have an ongoing metastatic breast cancer networking group that is run through the Cancer Institute, and I'm one of the facilitators of that. I see a couple of folks from our group on here today. And if you want more information about that, you can reach out to Kimberly Duncan at Northside. And you're also free. You'll have my contact information through Katie. I'll put it in the chat as well. You're welcome to reach out to me by email anytime you have questions. We can get these resources to you. So I'm going to move on to the question and answer period. Dr. Rangaraj, we had some great ones come through. Thank you so much for that talk. I think there's so much to say about this topic, so it's great to hear. And I think we had some questions. One person asked specifically if you could talk a little bit more about bone mets, specifically how those might look or be, like how they might present, I think is the question. So like, what would be the signs and symptoms of somebody that might be experiencing bone metastasis?
Sure. So bone metastases can be picked up incidentally on a scan that might be done for another reason, or you may have symptoms. So if you have pain in a joint, it's important to discuss that with your physician so they can get a proper imaging done. A common area for bone metastases is the lumbar area as well as the pelvic area. So now, of course, these areas are also places where people get arthritis. So if it's something new that's happening to you in the last 2 weeks, you're suddenly experiencing pain in this region, you've never had it, it would be important to talk to your oncologist about that so they can get either a bone scan or a PET scan or a CAT scan or maybe just a plain X-ray to look into it. Because, if you come in and say, look, I've had pain here for 5 years, it's likely not bone metastases, but a new pain or worsening of an old pain in an area of the body where there's a bone could be a bone metastasis. So, you would want to discuss that with your oncologist.
Thank you. We had another question from someone who says that she was diagnosed with metastatic breast cancer in May of 2021. It says third diagnosis, so I'm not sure if that was a recurrence, but she's on first-line treatment and is asking, when would I consider a clinical trial?
So clinical trial can be considered at any time, okay? So these are novel drugs, so they don't have a track record. We are trying to see if they will be effective. So if you're okay with that, knowing that this drug is not tested and you're very early on in your treatment, if you're okay with that, a clinical trial would be okay then. Now, some people would choose to go on with the standard treatments because they have been tried in clinical trials, they have a track record, they have been FDA approved. Some people will go that way and then they will consider a clinical trial later on, but really it's appropriate at any time.
Thank you. We have another question from a patient who says, I am a metastatic breast cancer patient with a BRCA2 mutation and interested in specific programs and groups that focus on this area, including providers. Is there anything you can suggest in terms of finding a provider who specializes or connects to this sort of high-risk breast cancer, maybe the hereditary breast cancer syndrome population?
Okay, so this individual has metastatic breast cancer as well?
Sounds like, yeah, metastatic breast cancer with a BRCA2 mutation, yes.
Okay, so there are several drugs that are approved for BRCA2 and BRCA1 patients, and these are called Parp inhibitors. And most oncologists are trained in treating these patients that are BRCA mutated. So in these individuals, chemotherapy is appropriate, but if there's not an urgent need for chemotherapy, they can be treated with PARP inhibitors first and then use chemotherapy later. But as far as providers, most are trained in taking care of BRCA positive patients. But now as far as genetic counseling is concerned for her family members or children, et cetera, then Northside has a really good genetics program that we, can get her in touch with. They're good at counseling and testing.
And I'm going to also ask Katie to put up an organization called Force that has some it's a national organization, but they have a peer match program and tons of information that might be helpful. So I don't know if that's exactly what you're wanting to connect with in terms of other people, but I'm going to have her
okay, that's
put
great.
that on here too. Yeah.
Mm-hmm.
But yeah, our hereditary cancer program, I can't say enough about the genetic counselors and their willingness to ask, answer questions. So I'm going to give you all my contact, and I'm happy for you to reach out to me with questions, that may come up in the future. So let's go to, I think, and you answered this one. This was, I think, the same person asking specifically about PARP inhibitors. So you just answered that question. So thank you. Can, Dr. Rangaraj, can you go back to the coping mechanism slide? One of the participants is asking us to revisit that slide again. So I'm not sure if it was just maybe some resource there or something that was wanting, something that she wanted specifically from that.
Is it the slide?
I'm not, maybe the reaching out for help. Was it maybe it was the mylifeline.org.
Okay.
You can get anyone that has questions after the program about anything content on the slides. We're happy to get that information to you, afterwards. So feel free. We got a couple more questions here. So Dr. Rangaraj, with one that came in was, is it true with metastatic breast cancer that I will be on active treatment forever? In other words, does my body ever stop responding to it? Or is there ever a time where you might go off treatment for a period of time?
Yeah, so yes, you will be on treatment for a long time. It'll be ongoing, basically. However, if your cancer is doing well, meaning the radiographs, imaging looks stable, and you're doing well clinically, a break is possible sometimes. So, that could be 2 weeks or 4 weeks or a month, or 2 months sometimes. A break is very much possible, but ongoing treatment is necessary to control the cancer. As far as your body becoming immune, really what happens is the cancer cells develop very sophisticated mechanisms by which they become immune to treatment, and basically treatment does stop working after a while, because there are these mechanisms that the cancer cells have of getting rid of the medication. They put up these barriers where medications, chemotherapy, drugs, etc., cannot enter the cancer cell, and that's how that immunity happens, where they stop responding to certain treatment, and then we have to just go ahead and change to a different type of treatment.
Thank you. So related to that, how does you talked about this in the presentation, but how would being postmenopausal affect the treatment options available? What sort of is different about a postmenopausal patient's treatment than maybe from an earlier younger patient?
Sure. So postmenopausal state would apply to the estrogen receptor positive patients only. Aside from that, it doesn't make a big difference. So if you are premenopausal, then there are certain drugs that we can use them, but we would have to deplete that estrogen by way of either injections, the Lupron injections and the Goserelin that I discussed, or sometimes we have to surgically remove the ovaries, and then we can use the treatment. But so it makes a difference if you're premenopausal. Postmenopausal state, you're really eligible for all treatment that is out there for hormone receptor positive patients. So premenopausal state would make a difference there.
And this one, I think this one comes up a lot. At what point should biomarker testing be done or redone? Is it something that I should ask my oncologist for, at any particular time?
Yeah, so if you are someone who had curable breast cancer or early stage breast cancer, and then sometime later you developed metastatic breast cancer, it would be important to check the biomarkers. They're done every time there's a biopsy at the time of diagnosis. So we routinely do the HER2/neu testing, the estrogen receptor testing, the progesterone receptor testing. But if you are someone who developed metastatic breast cancer a year or 2 or 5 or 6 years after having early stage breast cancer, biomarker testing should be redone, as 15% of the time that estrogen receptor, which was initially positive, may become negative or vice versa. And same is true with HER2/neu. If it was negative, it can be positive, vice versa. So repeat biomarker testing is very important. Also, this applies to the ER positive metastatic breast cancer. We do need the Pic3c mutation testing done at some point, because if you are positive, you might become eligible for that specific treatment.
Yeah, it's always changing and evolving. So, I mean, I think that's one of the things that's exciting about metastatic breast cancer research, is that there's, I mean, some of these treatments that you've talked about today with Parp inhibitors and such have really been, pretty recent discoveries. And
Absolutely.
So it's exciting to see. One more question. There are 2 more questions, I think, but this person says, my friends often ask when I'll be finished with treatment or if I'm cured. Any suggestions on how we can best explain that this is really a chronic disease that I'll be managing forever?
Yeah, I think sometimes the analogy of another chronic disease helps. Not to take away from the severity of metastatic breast cancer, but I sometimes say, well, think about diabetes, okay? Once you have diabetes, it's not going to go away. But if you treat it, you take your insulin and other medications, your blood sugars will be good, and you will live a good life without any complications. But if you don't take the medications, then your sugars will get up high, and then you could have some complications from the diabetes. So similarly, once you have metastatic breast cancer, it is oftentimes not curable, and treatment is ongoing. As long as you stay on treatment, you could expect to have a greater life expectancy than without treatment. So in that way, that analogy sometimes helps.
That's a great suggestion. And how likely is it, this is our question, how likely is it to receive a metastatic breast cancer diagnosis if you've been cancer-free for over 5 years from a previous early breast cancer diagnosis?
So that depends on what stage you were. So, and it also depends highly on the biomarkers. So, well, we'll talk about triple negative first. So triple negative cancer is one that comes back early on. So at 5 years, most of them have returned. HER2/neu similarly is one that comes back early. And so by 5 years, most of them, those that are going to return have done so. But hormone receptor positive is one that can come back 5 to 10 years later. So there, if you're stage 1, you have about a 7 to 10% chance of it coming back in 5 years. If you're stage 2, it's about 15%, or if you're stage 3, it's about 30% chance of it coming back at 5 years for hormone receptor positive disease.
Thank you. I've gotten a couple more. Are we okay on time? Do you have just a couple more minutes? Sure. Are we okay? Mm-hmm. Okay. And so this one says, how long are tissue samples retained after original surgery? So I guess the question is, how long would you be able to maybe, get a hold of the report for a surgery that was done in the past?
Sure. I think that's probably highly dependent on the institution. 5 years is not unreasonable that it would be there. I've not been able to find it at 10 years though. So
we typically rely on the report. Those go back a long way, but it is challenging to get the tissue. Although, I think some institutions do hang on. They have storage if they have storage for it, and they can keep it for a period of time. But yeah, that's been my experience as well. And we have just one more back to the PARP inhibitor question. This person says that she was not put on a PARP inhibitor despite having having a BRCA mutation. Why might that be? Why would that be that wasn't brought up? Can you think of what a reason might be? I know it's hard to talk to a specific clinical question, but
yeah. So was that a while ago? I would say, these are newer drugs. So if this is 5 years ago, then she probably would not have been offered that. But at the present moment, if you have BRCA mutation and you have metastatic disease, you should be offered a PARP inhibitor either before chemo or after chemo, but it should be in the mix someplace.
Yeah, and I think we can certainly, these are the kinds of questions that, we certainly want to empower patients to ask their providers and, feel the information. It may be the timing. Some of these, if they're clinical trials, they may be, there may be specific trials that are open in particular places. Of course, that treatment now is standard of care, so it should be available everywhere.
Right. And so if she had early stage breast cancer, just now we have gotten approval for PARP inhibitor in the adjuvant setting. So if she was early stage, she would not have been offered that unless it's, it's in the present day.
Well, I think that is everything that we were asked. So I think we've gone over a little bit, so 7 minutes over, but I just want to thank you so much, Dr. Rangaraj, for such a wonderful presentation and just so much information. I wanted to assure everybody that the information that's been presented is available. We're going to have this presentation recorded, so it'll be available on the Cancer Support Community website, and I'm going to invite Katie back to close us out and give us some final words.
Yeah, thank you both, Dr. Rangaraj and Emily, so much. Thank you, everybody, for the great questions. We got a lot of really good questions coming in. So as Emily said, a recording of today's event will be available on our website, cscatlanta.org, under that videos tab. And if you visit our calendar tab, you can see all the other programs offered, including that metastatic breast cancer program. And before we close, I'm going to put a evaluation form into the program chat box for these Frankly Speaking programs. We do kind of invite you to share your feedback so we can send them into our headquarter company and we can get these slides tailored to fit your needs. Put that into the program chat box in a minute. But again, thank you everybody for joining us. Thank you, Dr. Rangaraj and Emily, for being so generous with your time and expertise. Thanks again for joining us. Bye-bye. Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.